My name is Peter Morgenstern. I'm an assistant professor of pediatrics and neurosurgery at Mount Sinai, and I'm a pediatric neurosurgeon. So abnormal head shape in babies comes from really two things. One condition is called plagiocephaly, and the other is called craniosynostosis. The former is the common one. So plagiocephaly comes from essentially the pressure of the child's mattress on their developing skull. A baby is born with a skull that is not fully formed because it has to accommodate the growth of the brain. And so there's a collection essentially of floating bone plates that are not yet fused together into the finished skull. And this is very moldable. And so what ends up happening as we put children on their backs to go to sleep is that the pressure of the mattress slowly molds and flattens the back of the head. And that's called plagiocephaly. The other condition is craniosynostosis, which is an abnormal condition where one of those connection points between those floating skull bones fuses or closes too soon and causes the head to grow not in all dimensions, but in restricted dimensions so that it develops a deformity of the shape of the skull that is characteristic depending on which suture or connection point has closed first. So the first thing to do is to take your child to their pediatrician and point out the concern. I work with a lot of wonderful pediatricians, and they are very good at identifying one versus the other, plagiocephaly versus craniosynostosis. Plagiocephaly is an incredibly common condition, especially since the beginning of the Back to Sleep campaign and putting children on their backs to go to sleep. It is a safer way to sleep, but it does result in higher rates of plagiocephaly. But most pediatricians can pick out the difference between the two, except in the really rare and subtle cases where you may need a craniofacial specialist. On the rare occasion, I have encountered the parents occasionally who disagree with their pediatrician and feel that there's something wrong. They're just convinced of it, and I don't think it's ever the wrong thing to bring the question for another opinion. I say to all of my patients, you should never feel that you are offending me by asking for another opinion. If it were my child, I would always seek out an extra opinion if I wasn't 100% confident in the first. And so taking your child either to another pediatrician or to a craniofacial specialist, like myself, a neurosurgeon, or a craniofacial plastic surgeon, which is a plastic surgery specialist in this area, is never the wrong thing. So surgery is only required for craniosynostosis. Although plagiocephaly is the more common condition, it is not a condition that requires surgery, and it's rarely a condition that really needs any kind of, shall we say, invasive intervention. So I'll speak separately about the two. Plagiocephaly typically improves as the child meets their developmental milestones. Most babies, when they get to around 6 months, start rolling over. They spend less and less time on their back. For reasons that remain unclear to me, most kids sleep more comfortably on their stomachs. So once they're able to flip over, they do it readily, and they then choose to sleep on their stomachs when we can't choose for them anymore. And immediately, most kids will see improvement because they're, instead of spending 16 hours a day on their mattress, flattening their head out, they're now on their stomach, and the growth of the brain gradually rounds the head back out. And most kids continue to improve for anywhere from 18 to 24 months of age. And so you should plan when you start to see them reaching that milestone to see the beginnings of improvement in those first few months after meeting that milestone, and then continued improvement for the next year or so. On the rare occasion that a child doesn't improve as they're meeting their milestones, or if they aren't meeting motor milestones for some other reason, we think about physical therapy, which can sometimes help correct muscle tension issues in the neck, or give repositioning advice to parents to help improve or accelerate the rate of improvement. And if all else fails, we turn to a helmet. And helmets have been shown to help with correcting the head shape a little bit faster in kids who have not had success with what's called conservative management or watchful waiting with repositioning and physical therapy. I personally never turned straight to a helmet, but in in those rare cases where they aren't getting better, a helmet can be useful. Now, on the other side of the coin, craniosynostosis is a pathologic condition. So it's a condition where there's a problem, a physical problem that needs to be corrected. We correct craniosynostosis for a few reasons. One is that it can restrict the growth of the child's developing brain, and there is some evidence to suggest that that can cause cognitive delays in the future. The other is that restricted cranial growth can also cause elevated pressure issues in the growing brain down the road once the skull has completely fused and become a closed system. And the third is the appearance. So although it is a cosmetic and to some degree a cosmetic concern, any cosmetic concern in a child can create psychosocial issues in school. They could be picked on or bullied. And so in addition to just the appearance, we want to give every child as normal a life as possible. So that's the overall summary, I think, of the two. Surgery is typically required for craniosynostosis, but not for plagiocephaly. So this is a question I get from a lot of parents. Younger children, so children under the age of 3 months who are diagnosed with craniosynostosis can often be treated with a minimally invasive surgery. And what that means is the suture has closed, the bones have fused, but because their heads have not grown that much yet, the abnormal shape and deformity hasn't really set in. So we have the opportunity to intervene before that deformity starts to set in and give the child a chance to then grow normally after a surgery. So what we do in that situation is we make a very small, usually about a 1 inch or less incision over the affected suture of the bone, and we remove all of the bone along that fused point to then essentially recreate that area that allows for growth, recreate the suture line. After the age of 3 months, that intervention doesn't work as well because the head shape and the facial features have started to mature a bit more. Anything that affects the growth of the head also affects the growth of the face in a baby. And so we need to do a more significant operation to reshape the skull, which is, although a bigger surgery, remains a very safe operation, but it is more of an undertaking, requires a longer hospital stay. Both surgeries, when done at the right time for the right patient, have outstanding results and very low revision rates, so a very limited requirement for future surgery. So typically, no. So in my patients, one surgery is almost always enough. The rare exception is the child who has a genetic syndrome that's causing their craniosynostosis, which sometimes means that instead of having just one suture affected, they have multiple all over their head. And we need to sometimes do more than one stage of surgery in order to fully correct their head shape and allow for optimal growth over time. The vast majority of children who have non-genetic craniosynostosis can be treated with a single surgery, and the chances of needing a future surgery to fix a non-optimal result are extremely small. So in my experience and my practice, helmets are really used for a few situations. One is the child with severe plagiocephaly who is not improving with conservative measures, meaning repositioning physical and occupational therapy, and sort of adjusting to make sure that they're maximizing their time off of the back of the head or the flattened part of the head. The other is the child who has a chronic condition or illness that prevents them from meeting the motor milestones that will optimize their recovery. So if you have a child who is spending a long period of time in the hospital, is bedbound, and needs some other way to help adjust the head shape because all of the other external forces are working against them, in those situations, a helmet can be helpful. So it really depends on the surgery. So the children who undergo the minimally invasive surgery before 3 months of age typically spend 1 night in the hospital, sometimes 2. The surgery itself only takes about 1 to 2 hours at the most. And after that 1 night in the hospital, they go home. And after a couple of days, they can bathe and wash the area. And depending on how you define recovery, it's very brief. Most kids are back to behaving like their normal selves and eating completely normally within a few days. The larger operation for craniosynostosis after 3 months of age is typically anywhere from a 2 to 5 day hospital stay. There's usually some scalp swelling, which I find with babies that the pain is typically very well tolerated, and we can give some pain medicines that can help control it. But babies typically need very little actually to control the pain, which is great. Much less certainly than you or I would if we underwent a similar operation. The thing that really upsets them is the swelling, because often it means that the eyes can't open all of the way, and they get really frustrated and disoriented and itchy. But usually that all resolves within a week. And certainly by the time they go home, I make sure that before they go home, they're not in sort of an extreme level of fussiness that is going to be difficult to manage at home. And then in terms of returning to completely normal behavior and activity, that's usually around the time that the swelling starts to resolve. So a week, 2 weeks at the most before they're really taking in an equivalent amount of food and drink and behaving like the baby that you remember.